Health literacy is what I call the sleeping giant. We don't know about it, but it's hitting us, it's striking us from every angle, and we just don't recognize it. A lot of the disparities in healthcare are really a result of health literacy. And so that trend is there. And if you want to fix it, I mean, don't marvel at the problem. You've got to go back and fix the cause.
This episode of PopHealth Week is brought to you by Health Innovation Media. We create thought leadership content that supports your value proposition narrative via original or curated digital assets for omni-channel distribution and engagement via our signature pop-up studio. Connect with us at www.popupstudio.productions. Welcome, everyone. I'm Gregg Masters, Managing Director of Health Innovation Media and the producer co-host of PopHealth Week. Joining me in the virtual studio is my partner, co-founder, and principal co-host, Fred Goldstein, president of Accountable Health, LLC. On today's episode, our guest is Joseph Webb, Doctor of Science and Fellow of the American College of Healthcare Executives. Dr. Webb is the CEO of Nashville General Hospital, a 150-bed academic system with more than 22 clinics, and serves as the teaching hospital of the historic Meharry Medical College. Dr. Webb earned his Doctorate of Science in Health Services Administration from the University of Alabama at Birmingham. And with that brief introduction, Fred, over to you.
Thanks so much, Gregg. And Dr. Webb, welcome to PopHealth Week.
Well, thank you. It's a pleasure being here.
Yeah, thanks so much for joining us. Really looking forward to this conversation. So why don't we start a little bit with you providing a little bit of your background and information about Nashville General, the hospital itself.
Okay. My background, like you, I've spent a number of years in healthcare and healthcare leadership. Actually, I began my career in behavioral health. I managed behavioral health hospitals in a for-profit system. Later moved on to acute care with the system out of Memphis, the Methodist healthcare system, Methodist Le Bonheur healthcare system. Spent a number of years there. I'm a graduate of Tennessee State University, HBCU, with a bachelor's and a master's, and a second master's from the University of Alabama at Birmingham in their healthcare administration program, and a doctorate from the University of Alabama at Birmingham in their doctorate in health science, health administration. And so that's kind of my lead up to where I am now as the CEO of Nashville General Hospital. Now I'm celebrating, actually at the end of this month will be exactly 7 years. And so we've had a good run here. It's essentially been a turnaround. I have a great team that we've pulled together to manage that. So we have some excellent programs in place, and our mission just to get things out and into the open here as a safety net hospital, a metropolitan public hospital, Nashville. Our mission is to improve the health of the population by providing equitable access to coordinated and patient-centered care. And we do that regardless of an individual's ability to pay. And now that is a tricky equation, as you know.
Absolutely, absolutely. And it's fascinating that you mentioned early on your original work was in behavioral health. I too spent 6 years in for-profit behavioral health hospitals running them as well. And I would assume that allows you to look at things a little bit differently, particularly within populations you're dealing with in Nashville.
It absolutely does. And honestly, I saw that in your brief description there of your background. And I said, you know what? It sounds like I'm talking to myself. I'm going to be talking to myself because once you understand behavioral health and how it impacts the overall healthcare, it's stated that 1 in 3 individuals will experience some form of, mental health or behavioral issues, health issues during the course of their lives. And unless we know how to address that as a part of an illness and not just as something that is shunned by society, then we're not going to be effective with caring for our overall population. So it's very critical. It's a very critical aspect. And most, as you know, most hospital CEOs are really not that familiar with behavioral health and really would rather not be so much a part of their delivery system.
And that just gives you a unique lens, I would imagine, on the overall approach that you're sounds like you're trying to do with some of these other unique programs. And could you talk a little bit about? I understand the hospital is about 150 beds. Is that right?
It is licensed 150 beds. We're not operating all 150 of them, usually about up to 110, 115, which is about where most hospitals operate in their percentage of capacity. So yes, we have created a couple of programs here that just to give a quick background on why we did that. The chronic care model, which I saw some of that in your description as well. The chronic care model, which was created at the McCall Institute by Ed Wagner, you're probably familiar with that. Michael Parchment is now the director over that. Ed Wagner was his predecessor. And so the chronic care model, which we established that, and it covers the scope and the framework of how we want to deliver healthcare. But one thing about the chronic care model is it doesn't provide you with all of the operational activities that you need. And so what we did was we integrated the patient-centered medical home model and patient-centered specialty practice model, NCQA model, into that because it has over about 140 elements, has 6 standards and about 140 elements, which as I was reviewing opportunities to address chronic care, I recognized that the patient-centered medical home model actually operationalizes the chronic care model. And it gives you very rigorous standards and structures and processes that you can put into place and actualize the chronic care model. So that's really what we do here. We integrate those two models and quickly recognize that roughly 50 million or more people in this country struggle with food insecurity. So food insecurity is a very daunting task for most because it's stated in the numbers that 1 in 3 adults in this country will experience that and will have difficulty with and once they reach a certain age, acquiring their medication and or food or both. So oftentimes that choice has to be made. The other piece of that is food insecurity drives individuals to more than likely rely on food that is very non-nutritious. And we know food is medicine. We are what we eat. So if you're prone to chronic conditions and you're eating foods that are high in, everything, sugar, carbs, and all of the stuff that you don't need to be putting in your body that's causing a lot of inflammation within your system, then you're just going to exacerbate what is inevitable to be chronic conditions, right? Whether it's congestive heart failure, diabetes, or hypertension. And oftentimes, when individuals are categorized, if you're risk stratifying and individuals are categorized in that 5 to 10% that's going to consume, and as a former CEO, you know this, they're going to consume anywhere from 50 to 70% of your resources. And now, so what you have to do is you have to stratify that population. And once you can do that, then you can identify their needs. And 9 times out of 10, there's going to be a behavioral health challenge within that high risk population. And so if you can figure out a way to address the behavioral health piece, and you can figure out a way to address the food insecurity piece, then you're likely to be able to put that individual on a pathway to better health. So how do you address that food insecurity? What we did, and this was a creation here at the hospital. I spent about 14 of my years in the Memphis market on the board of a food bank, the Mid-South Food Bank. It was tri-state, Tennessee, Arkansas, and Mississippi, and we delivered, distributed about 20 million pounds of food per year. But one thing that I never could get a really good grasp on with delivering at that kind of capacity was making that food nutritious, because you had to rely on all different sources. So fast forward, coming into this environment, I knew we needed to address an issue with food insecurity, because the population that we serve, being basically that disproportionately indigent population, I knew that we would have some food insecurity matters going on, and that would exacerbate the care, and it would drive up the cost, and it's not healthy for the patient. So the way we did this was, every patient that comes into contact with a hospital through whatever entry point, ER or direct through the ambulatory division, is administered a food insecurity assessment. Now, if what we call it, if they test positive for that, then what we do is we have that provider will write a prescription that will go into the electronic health system for that individual to receive food from the food pharmacy. Well, there are registered dietitians that are in our food pharmacy, and a food pharmacy is set up kind of like a grocery store. It has aisles. There are aisles of food that are low sodium. There are aisles of food that are low in sugary and carbs. And then we have a cancer care program here. So there are foods also that are high caloric for our cancer patients. And then there's the coolers with the fresh fruits and vegetables. So the dietitian will walk the individual through to select the foods that matches up with their prescription. They get a tote bag, and they oftentimes will have a family member with them. And so they're also instructed on how to prepare certain foods. And if they ask, then that dietitian will also give them some recipes that are available for preparing foods that they need. So that's how the food pharmacy works. They're initially given 12 weeks of food. And then, if you're familiar with the chronic care model, the first item to the left of the chronic care model is community resources. Our managed care portion of our ambulatory division, our LCSW, works with the patient population to make sure that they are searching to find community resources that can support them and to help them move them along socioeconomically. So we try to get them transition off of the food pharmacy if it's possible, but we don't just kick them off. So that's how that works.
And you'll give them a source or a resource that they can then go to continue to get the food from a food bank or another group like that.
And now they're still a part of we don't remove them from our care management portion of our ambulatory services here. So once they're under that umbrella, unless they select out, they remain a part of our population of patients.
And so is your care management team, that LCSW you talked about, continuing to follow up with them at various periods of time, depending on severity level or things like that?
Oh, yes. They have regular follow-up visits that are tracked and monitored. And the care management team is a part of the overall ambulatory division. So we have a number of specialty clinics, and we have primary care clinics. And so there are intra, I should say, referrals going on all the time.
And I know that, some of these things are a little bit hard to measure impact of, but have you been able to see any sort of impact yet in terms of measurements of individuals who are going through that program, perhaps seeing differences in weight or clinical status? Or is it still pretty early for that?
No, it's a great question. And we have seen some results. Our diabetic patients, as you know, you look at A1C, and what we're doing is tracking A1C under control. So, anywhere, I think it's like 8, maybe 9, or under 8 or 9, considered as being under control. We went from 38% under control. We were at 69% under control. Now, hypertension is a tough nut to crack. and you're measuring blood pressure. So for that one, it's a little, it's less of growth, but it's still the incline is still going. So it's just more difficult to manage, but we're seeing improvement there as well. Now, let me just share this with you. Our patients in the cancer care program, when we had our accreditation, triennial accreditation, that association, the group that does the accreditations for cancer programs, what they noticed was an improvement in the individual patients' in our survivorship. And one of the things that happens with the food pharmacy, which was an unintended benefit, I was not aware of this when we were working on putting this program together, but our patients in the cancer program oftentimes are individuals that have exhausted resources and they've had to come to us for cancer care. But whether they have done that by transferring to us or they started with us, that still happens. And individuals that are receiving chemotherapy or other cancer, care agents have to maintain a certain weight level. Otherwise, you would have to discontinue that treatment until they can get their weight level up. Well, what this does is if an individual is struggling with food insecurity, then they never have to experience that because we have that component of high caloric foods that I described to you earlier right there in the food pharmacy. So they just get a prescription to the food pharmacy and there you go. So that's how that works. But we saw that and that was recognized under that accreditation and they pointed it out to us that this is an amazing accomplishment that these patients are actually showing better survival rates because of their ability to maintain their weight and to tolerate their treatment.
And if you're just tuning into Pop Health Week, our guest is Dr. Joseph Webb, the CEO of Nashville General Hospital, a 150-bed academic system with more than 22 clinics that serves as the teaching hospital of the historic Meharry Medical College.
That's fantastic. That's a great point. And some of the things that sometimes you pointed out, some people don't consider, hey, you work and fix this one and you suddenly see this spillover effect that leads to a better outcome. Really fantastic. I know you do some other programs too. You've got I guess it's called the CHEN program, the Congregational Health and Education Network. What's that?
Well, you nailed that. Most people don't get that name right, but that's exactly what it is. It is it is a faith-based initiative. And as you said, Congregational Health and Education Network. That is exactly what it is. We have now probably about 110 congregations, and the number continuously grows as other congregations become aware of it. But that is basically centered around health disparities, reducing health disparities. As we know, social determinants of health are the fundamental causes of health disparities. And the social determinants of health being items such as food insecurity, education attainment, access to housing, access to transportation, access to healthcare. Those are all social determinants of health. And if those are maldistributed among populations, then you're going to see that maldistribution of those health disparities as well. So we know that there are certain populations of individuals who tend to rely heavily on their faith-based organizations, and that science has shown that, particularly African Americans, and there are some other populations that do that. But so what we've done is we have created this network that focuses on health disparities. It is now a 501c3, just recently received a fairly decent sized grant. And so it's definitely off and running. We focus on, obviously we focus on health disparities, but the way we go about doing that is to attack it from an educational attainment standpoint. Because here's the reason we do that. Of all of those social determinants of health that I just mentioned, education attainment is the one that will impact the others at a higher, if you're a statistics geek, R score, or you could say has a greater correlation than the others. And so if you improve your transportation, that doesn't change necessarily the other social determinants of health. But if you improve on your education attainment, then the likelihood of your being able to be at a different socioeconomic status becomes very high. And so longitudinally, what we're doing is working with individuals through particularly our health sciences program here at the hospital and local colleges and universities to, and we haven't reached as much, we haven't gotten as much traction across all of them as we would like, but the system is in place and we're moving in that direction. So education attainment, and then there's health literacy, and then there's access, obviously access to healthcare and supporting the faith-based congregation. Those are the four pillars that fall under the Congregational Health and Education Network. We call it SHIN. But the premise is this: you cannot achieve health equity until you achieve a more equitable distribution of the social determinants of health.
Yep, absolutely. And a question on that, because most people focus on health literacy, but it sounds like you're actually pushing for a more broader education program to get people through various levels of education. Is that part of this?
Well, interesting. That's a good question. Education attainment, based on that correlation, that strong correlation, and all science and research and all that will show that correlation. We're evidence-based. We're an evidence-based healthcare delivery system. And evidence-based has always been in the medication aspect, but evidence-based has not always been in the management side of healthcare delivery, okay? So we're focusing on all items that we engage as tools into our delivery process is deeply rooted in empiricism or evidence. And so, yes, education will tend to change the trajectory of an individual's life. So we can focus on that. Now, health literacy is a different animal. Health literacy is, I don't know if you're aware of, there's a tool health literacy that was also created by the McCall Institute that created the chronic care model, and it works collaboratively with the chronic care model. So we have integrated that into the 6 standards of the chronic care model, and each standard has an element of health literacy that it addresses. So our goal is to weave that into the chronic care model. So it's not something we're trying to take on independently of our overarching framework for healthcare delivery.
Absolutely. I just thought it was fascinating when you talked about education, because what I was getting at it in a sense is, are your programs helping people stay in school or continue their education and focus on that through the CHEN network?
We're just starting to get traction in that area. What we're doing is there's a workforce development component. We have one of the local healthcare systems who has created job opportunities for individuals in some of the health sciences studies that we provide here. We're looking to expand the program and continue to grow it, but our RAD Tech program, our nursing assistant program, and our EEG program, tech program, EKG tech program. And so those are starting points of where individuals, it's amazing because a RAD Tech is a 2-year endeavor, and a smart kid coming out of high school that hadn't decided whether or not they want to go to college for 4 years or not yet can go into that program, and in 2 years they can earn $60,000 to $70,000 depending on the area of the country they're in, and that's a pretty good living for a 2-year education. And so that's what we're pushing and promoting. We have a very small group, and it's not very diverse right now. And so we're looking to bring on more diversity because, the cost of the program could keep some people away. That goes back to that social determinant of health. And so if you can, and as I say, if you can mitigate the social determinants of health, the impact of the social determinants of health at the local level, you have to prepare to mitigate those social determinants of health, because if you can't do that, don't expect it to come from on high. And those are upstream, and they're not about to flow downstream yet. But if you can mitigate the impact of those social determinants of health, which is what we're doing, then you can change the trajectory of your patient population.
I know the audience can't see this, but I'm smiling ear to ear listening to you, because what you're talking about, most people say, we're going to go solve health literacy, but you're actually trying to solve for that and saying, hey, we're going to help individuals get through a 2-year program or get this other thing to help them lift up to create and solve for those social determinants of health. Fantastic. It really is great to hear you talking about that.
Yeah, you can be as literate as anyone else in the world. Only 12% of our population is health literate, by the way. But you can be as literate as anybody. But if you don't have the means to access healthcare, right? So that becomes, it's not, I don't mean to imply that it's secondary, but I am saying that it is a part of the overall process that we're putting into place, the framework that we have in place. We don't ignore it. It is very much integrated into our system.
Well, unfortunately, we've got just a few seconds here, maybe about a minute left.
We're out already?
Yeah, it's been great. I'd love to get you back, Dr. Webb. It's been fantastic. And talk some more about what you're doing. Really quickly, what has allowed you to turn the system? What, culturally wise, et cetera, what have you done? Because it sounds like you've made some great progress in areas.
I think the first thing you have to do is meet the people where they are. Hospitals, the public hospital is always going to have a challenge. Politically, socially, economically, it's always going to have a challenge. And we can look at that on a broader scale, and we can talk about that sometime. But it's no different when you're dealing with the local, public hospital. And so you're dealing with the issue of funding. And so what we've done here is to try to make sure that the cost of care to this large population that we serve is minimized. Our goal here, our strategic goal, is the triple aim, and that is the patient experience, the outcomes of the patient's care, and the cost per capita. We know that we're at close to 20% of the gross domestic product as a country for cost of healthcare. And so we consider all of that, and what we attempt to do here is to mitigate the impact of that by making sure that our cost per capita, per patient, is as low as we can get it by doing things like the food pharmacy that causes that at-risk patient to not to have to drive up their costs by showing up in our ER and having to be admitted to the ICU for a diabetic crisis that was avoidable had we done the right things.
I really want to thank you for coming on, Dr. Webb. It's been a pleasure to have you on PopHealth Week, and we'll have to get you back.
All right. Thank you. Happy holidays, by the way.
Yes, happy holidays to you. And back to you, Gregg.
And that is the last word on today's broadcast. I do want to thank Dr. Joseph Webb, the CEO of Nashville General Hospital, for his time and insights today. Do follow his work on Twitter via I am Joseph Webb and at Nash Gen Hospital, respectively, and on the web via www.nashvillegeneral.org. And finally, if you're enjoying our work here at PopHealth Week, please like the show on the podcast platform of your choice and do share with your colleagues, and do consider subscribing to keep up with new episodes as they're posted. For PopHealth Week, my co-host Fred Goldstein, this is Gregg Masters saying, please stay safe, everyone.